Recognition of both short and long-term complications after the lap band system surgery by all healthcare professionals involved in the patient's care is key to successful outcomes. It is equally important to educate both patients and other healthcare professionals regarding possible complications in order to provide appropriate and timely care. Complications can be easily recognized and successfully treated, especially if diagnostic and management protocols are in place and are followed by all members of the team, including the patient's extended team of PCPs and other healthcare practitioners. Inform PCPs of possible symptoms, such as GERD, vomiting, or chest pains that may be associated with the lap band. Key to successful outcome. Understand the signs and symptoms of short and long-term post-surgical complications. Develop diagnostic and management protocols regarding complications to be followed by all members of the team. While early serious complications are rare, all staff involved in working with patients who underwent lap band system surgery need to be aware of symptoms and signs suggestive of gastric leak or perforation, deep venous thrombosis, venous pulmonary thromboembolism, or early signs of access port site infection. An upper GI series with contrast, barium used most of the time, in all patients after the surgery ensures that the band is in the right place and that liquid flows normally through the band. The lap band surgeon needs to read the films or train a designated radiologist. Standard postoperative orders that emphasize the appropriate postoperative behaviors and discourage any behavior that can lead to a complication should be given to each patient. Long-term complications associated with the lap band system surgery are not as rare as short-term complications. They generally result from the implanted device and are quite specific to laparoscopic adjustable gastric banding surgery. For instance, band slippage rates may increase over time, with the cumulative rate of a band slippage increasing from 0.2 to 0.3% in the first year to 5 to 12% after several years, depending on the time and the surgical technique used. Dr. Paul O'Brien and colleagues, and then Dr. Ponce and colleagues, reported on the decrease in long-term complications after the adoption of the pars flaccida technique versus the perigastric technique. In patients operated on using the perigastric technique, 20.5% of patients had a gastric prolapse versus 1.4% when using the pars flaccida technique, both within a comparable period of time, 12 to 13 months after surgery. There is also early indication that hiatal hernia identification and repair may translate into decreased rate of complications and revisions. Gastric outlet obstruction. Common causes. The band is too tight. Slippage or prolapse of the stomach through the band leads to an abnormally enlarged pouch of stomach above the band. Symmetrical enlargement of the pouch above the band associated with pressure and stretching. This may involve symmetrical gastric pouch enlargement, stretching of the lower esophageal sphincter, or the development of a hiatal hernia or esophageal dilation. All of these complications produce similar symptoms associated with obstruction. Stasis and gastroesophageal reflux. Two important aspects should be emphasized. A, abdominal pain is rare and a major concern. If it is not resolved with the removal of saline from the band, immediate referral to the surgeon is required. B, obstructive symptoms may include or consist exclusively of sleep disturbance or respiratory symptoms. Recent onset of the following symptoms should alert the healthcare professional to consider the band as a possible cause: chronic cough, recent onset asthma, recurrent or prolonged bronchitis, pneumonia. Number 2, erosion of the band into the stomach. Usually indicated by an insidious reduction in the band's efficacy and weight gain. Many band erosions are silent and totally asymptomatic. Development of a late port infection is thought to be a late sign of band erosion as bacteria has ascended along the band tubing to the access port. An upper endoscopy is indicated to look for a band erosion whenever a late, persistent port infection presents. Number 3, tubing and access port complications. System leaks, tubing kinks, port infections, and malposition. Band erosion should be included in the differential diagnosis of late infections at the access port site. This may result from migration of the stomach contents along the access port tubing.
Managing complications. Typically, standard diagnostic protocols are employed to manage non-urgent complications. Diagnosis of pouch dilatation, slippage, and prolapse is achieved by using an upper GI series. The fluid from the lap band system should then be removed as an interim measure. Significant gastric pouch enlargement is addressed by revisional surgery. Erosions are typically diagnosed using upper GI endoscopy. The eroded band is then removed. This procedure is most often scheduled as an elective, non-urgent procedure. Although there is not a consensus on whether or not to reband a patient with previous erosion, surgeon presentations at the American Society for Metabolic and Bariatric Surgery conferences suggest waiting 6 to 12 months before banding the patient again or using an alternative bariatric procedure. Band erosions may be related to serosal injury at the time of the procedure. However, the exact mechanism or cause is unknown. Incident decreases with surgeon experience, which suggests some technical component. For instance, Dr. Weiner and colleagues experienced 2 band erosions in their first 100 patients and only 1 band erosion in the following 884 cases. Port problems, such as infection, leakage, and port flip, may occur. Access port problems have been widely experienced, and revision of the access port is not considered an office procedure. It may require laparoscopic surgery to retrieve or reposition the tubing. How can the risk of post-surgical complications be reduced? Meticulous attention to surgical technique. Treating or closing all large hiatal hernias. Gentle dissection and tissue manipulation may prevent an erosion. Patient education and re-education. Consistent follow-up.